Okay, Dr. Liu is not here, so I'm going to have the honor of introducing our next speaker, who I'm sure you have already heard mentioned today. This is Dr. Oberg.
So, good afternoon, ladies and gentlemen. I'm happy to see that some of the patients I've seen this week are also here to listen. So what I will do now is actually to delineate a treatment algorithm for these tumors, taking into consideration tumor biology and also other factors. So to start with, I just want to point out that I'm only going to discuss typical and atypical lung carcinomas. I'm not going to cover the field of large cell or small cell tumors. Again, you know that these are not so rare as people have pointed out during this morning. And we expect to see it has around 27 to 30% of all neuroendocrine tumors, and they are steadily increasing in number and incidence. Many people have mentioned Laennec, and maybe it's good to see how he looks. So he was the man who reported in 1831 the first bronchial carcinoid. So he is also well known for Laennec cirrhosis of the liver and so on. So he was a quite active pathologist. Again, 1 to 2% of all lung malignancies in adults are lung carcinoids. And you have seen also the figures of the women are slightly more affected than men, as we heard, and the peak incidence around 50 years. So which are the cells actually that are responsible for development of these neuroendocrine tumors of the lung? And I think I have put down these are the tumors. They are spread out the bronchial mucosa together with other factors. For some reason, these start to grow, and we have heard this morning about the deep necks and tumorlets and also carcinoids in the final end. So these pulmonary neuroendocrine cells, they are distributed all over the bronchial tree. They have local paracrine and neurocrine effects, so they regulate the tonus of the bronchus. And they can form bodies. So several of these cells can go together, and then they form so-called neuroepithelial bodies. And these are mechanoreceptors and also nociceptors. So they regulate the exchange of, for example, oxygen in the lung. And we have heard this morning, I'm not going in detail back to the deep necks, but these deep necks, they are proliferation of such NEBs, neuroepithelial bodies. And they can grow up to tumorlets, less than 5 millimeter size, and then they can become tumors, carcinoma tumors, when they reach about 5 millimeters. I think it's very important also to realize that this is a common condition if you are living in high altitudes. So people living in the Andes, these high mountains, 6,000 meters, about 50% of the people there, they have deep necks. And they are living with deep necks. And this is an adaptation to this high altitude. So they had to have this to regulate the oxygen supply to the body. We have heard about the WHO classification. I will not bore you with this again. So, and we have also heard that 75% of the tumors are located centrally and around 25% locally in the lungs. We have also heard about that these tumors present metastases, and as you can see, the atypical ones have more metastases than the typicals, and this is a rather small series, but you can see they go mainly to liver and bone. Sometimes you even see brain metastases. And you also saw this morning from Dr. Ramirez that lung tumors in general have a worse prognosis than other neuroendocrine tumors. But you can also see that if you look at this figure, so with this as a background, I now move into treatment. And the problem has been with medical treatment of neuroendocrine tumors. It's no doubt that surgery, and surgery is first, up to fourth line treatment in these patients. But we need other types of treatments as well. And there have been several systemic treatment approaches over the years, but mainly phase 1, phase 2 studies. We had, luckily now, one phase 3 trial, which I'm coming back to, which is the first one actually indicating the role of everolimus or afinitor in neuroendocrine tumors. We have also another trial which I'm going to mention to you that is just finished, also indicating the role of everolimus or afinitor in lungs. There are very few other studies that can support what kind of treatment you should select. And therefore, most of the treatment schedules and algorithms has been eminence-based medicine, not evidence-based medicine. But we try to move into evidence-based medicine also in this field, as we have done in other areas of neuroendocrine tumors. So these are the options that has been talked about earlier this morning and also quite recently by our previous speaker, indicating the role of surgery. And I'm going to touch on radiotherapy, not the traditional one, but PRRT, cytotoxic treatment, everolimus, biotherapies, and of course symptomatic treatment. So there are very small series with PRRT, peptide receptor radiotherapy in bronchial tumors. There are some European studies done in a limited number of patients. One is from the group in Rotterdam, where they included 9 patients, and they had 5 partial remissions. You remember what we mean with partial remission and stable disease and complete remission and so on. So, and the median time to progression was 31 months, which is quite long in this group. The other study is from our group, Dr. Granberg, 12 patients, 6 partial remissions. So 50%, about 50% responded to this kind of treatment. Then we have a larger study from the Basel group with using yttrium dotatate. And they included 84 patients with 24 partial remissions with a response rate of a little bit lower than 30%. And there again, median survival 40 months. So if you have a response, you have long durations. More data is coming out. From our own center, we have now treated about 50 patients with bronchial carcinomas with PRRT. So I mean, the data are coming out, and what I can say is that this seems to be a rather effective treatment for both typical and atypical lung carcinoids, provided that you have a positive gallium PET or octreosca. If you look at chemotherapy, I just took this from a textbook, quite recent textbook. And you can see something which is rather strange. If you look at, they include temozolomide plus capecitabine plus minus Avastin or bevacizumab, but they also put in everolimus plus sandostatin LAR, and that is not chemo. So this is a new textbook in endocrinology. So, but all the others we can keep there, but take out everolimus plus sandostatin LAR and coming back, because this is a targeted treatment or biotherapy. If you look at bronchial carcinoids and treated with temozolomide, and this is a study from our group as well. Dr. Krona published it in 2013. It's a rather small series again. It was totally 31 patients, 14 typical carcinoid, 15 atypical. And we had 3 partial remissions, 14%, 52% stable disease, which is quite good because all these were aggressive tumors with tumor progression. All the responses with partial remission were seen in atypical carcinoids. So that further show you that the best responses with chemo is seen in patients with aggressive tumors, high proliferation. So if you have a tumor with very low proliferation, 2 to 3, 4, 5%, you should not go for chemo in the first line. So the conclusion is that temozolomide might work, and we need to make, of course, a randomized controlled trial to really demonstrate the role of it. But it's there on the list for treatment of carcinoma, lung carcinomas. I just want to show you one patient. This was a patient that came to me in 2007 from Hong Kong with an atypical lung carcinoid with 95% Ki67. You can imagine 95% Ki67. He had received cisplatin and etoposide 6 cycles, and he was almost dying. He came with ambulance from the airport. So I was thinking, what can I do for this gentleman? He was 45 years old. And so I constructed then a combination of capecitabine plus temozolomide, Temodar, plus bevacizumab or Avastin. And you can see that already after 4 months is almost complete free of tumor. You see on the FDG PET that it is widespread disease. And I am followed him now. He's coming to me actually next week for a visit, but he has sent his FDG PET to me, so I saw it yesterday on my computer. It's still free of disease 10 years later. He's now living in Vancouver. So if you look at other chemotherapy studies, this is a rather small group, also 34 patients with atypical carcinoids, so the more aggressive type. They selected for either streptozotocin plus 5-fluorouracil or cisplatin plus etoposide. And you can see a rather good response rate with partial remission in around 35%. So it seems to work also in high-grade tumors. Then we go to mTOR signaling. And this might be a little bit tough for you to understand the full details of it. But we have several signaling systems that regulates the tumor growth, the tumor cell growth. So there is a switch that's put on the cell to grow and not to die. And one of these systems is called mTOR, and that is found in most neuroendocrine tumors, but is particularly upgraded or activated in lung nets, both typical and atypical lung tumors. Not so much in small cell or large cell tumors, but in typical and atypical lung carcinoids. And that was, of course, one of the bases for looking at the substance that can block this signaling. Can we wipe it out? The tumor should stop to grow. And there we have the affinitor is coming in. And you can look at factors that are regulated in this signaling pathway. You can look at AKT, you can look at mTOR itself, phosphorylated forms, and you can see how often it is up or down regulated. This is overdoing at the moment, but I must say that it's no doubt that this system is a central regulator of the tumor growth. And therefore, I think when we have now the data with affinitor, which is blocking this system, we understand the biological background. So the first study that started to indicate that there might be a benefit of affinitor was the RADIANT-2 study. And that study was originally thought to be a study for midgut carcinoma tumors. So patients with carcinoma tumors of the gastrointestinal tract should be included. But for some reason, in different centers, they started to include other patients as well. And the problem was that when we started to evaluate this study, we couldn't reach the goal that we had set up for this study. So the patient received either placebo or the everolimus affinitor, 10 milligram a day. And here are the results. You have seen this type of curves before, but it should be separated if you should demonstrate an effect of the compound everolimus. And unfortunately, we didn't reach that. And that was partly related to that different types of tumor were included that was not meant to be there. But they were interesting because if we look at subgroups of patients, we could see that the rectal carcinoids were doing fine with this compound. But we also saw that there was some indication that lung nets might benefit from this type of treatment. If you follow the red line, you can see that at least in the beginning, there is a separation of the two curves compared to the placebo, the yellow one. So that formed the basis then for the next trial, where we want to study more exclusively lung nets. There are some sub-analysis from the RADIANT-2 study, which I think I should also show to you. You see that the arm with everolimus or affinitor had a significantly higher median PFS, progression-free survival, compared to the placebo. And you have seen this so-called waterfall plots demonstrated by Dr. Ramirez this morning. And you can see this is for the active compound and this is for the placebo group. You will see that there are more patients that responded in some way. So that formed the basis then for the RADIANT-4 study, which was exclusively done for patients of non-pancreatic tumors. So it was included both small intestinal, but a lot of lung carcinoids, as well as rectal carcinoid, colonic carcinoids, and so on. And they were randomized to get either everolimus, 10 milligram per day, or placebo. And this time without any addition of somatostatin analog. If you look just at the lung group, you can see that they constitute about 1/3 of the patient in this large study. And and if you look between the two arms, the placebo arm and the everolimus arm, this is very important to look at. You can see this is a very well-balanced, the type of tumors that were included, and the age and the WHO performance and so on. So it was a well-done study, excellent study. And this is further underlined if you look at other things when you look at the study. And here you have again a waterfall plot, and what you see here is again that you have with the active compound, afinitor, significant more tumor shrinkage compared to the placebo group. So this was very promising. And if you look then at these curves, you have seen this in the morning by Dr. Ramirez, looking at progression-free survival. There is a significant difference, 11 months median in the treatment group compared to the placebo, only 3.9 months. So this clearly then indicating that what we saw in the RADIANT-2 trial as an indicator of efficacy of everolimus in lung tumors is now fulfilled in this study. And looking at subgroup analysis, you can see that actually lung are doing the best. So they are doing even better than gastrointestinal neuroendocrine tumors. So based on these, just for a couple of weeks back, Afinitor, everolimus, is registered both in Europe and in the US for treatment of patients with lung neuroendocrine tumors, typical and atypical lung cancers. And this is a randomized controlled trial. It's really evidence-based medicine. It's not eminence-based any longer. So this is just a summary and conclusion of the study. I don't have to go into details of it, but it is a significant efficacy compared to placebo in this study. So based on what I have been saying so far, at least at our center, we have some view of how we treat our patients with lung neuroendocrine tumors. So if we have patients with low proliferative rate, T67 less than 3, 4, 5%, we give somatostatin analogs, we give interferon alpha. I didn't talk so much about interferon alpha because it's not used so much here in the US, but we have in the room a patient that has been taking it for 18 years, and she is in excellent condition and have no tumor growth. So, and we know from we know from our patients in Europe that it's an active compound for this low proliferative tumors. Lutetium is another option in patients that are starting to progress on first-line treatment. And everolimus is now also included in the standard treatment protocol, alone or in combination with somatostatin analog. Then we have the intermediate group, T67, 5 to 15% about. And there we have temozolomide, as I pointed out, alone or in combination with capecitabine. Lutetium PRT is still an option. And again, everolimus plus minus sambostatin or other somatostatin analog is also possible. High proliferative rate. above 20%. This is a difficult group. And of course, this had to be looked more carefully in the future to see if we can subdivide it into smaller groups. But cisplatin and carboplatin plus etoposide is still a standard treatment. But more and more, at least in Scandinavian countries, they started to use my triple combination, temozolomide plus capecitabine plus bevacizumab or Avastin, as I showed you in these patients from Hong Kong. And we have seen some very good results in other subtypes of tumor, not only in lung, but also some pancreatic mets. So, what can we wait for the future? I think Eric is going to talk about the trials, but I just mentioned the LUNA trial, which I've been deeply involved in myself, and that is a combination of pasireotide, which is another somatostatin analog. This somatostatin analog is binding to 1, 2, 3, and 5, receptor 1, 2, 3, and 5, not 4. And it's used for acromegaly and also for morbus Cushing. But it has not been so effective in traditional gastrointestinal and neuroendocrine tumors. But I can tell you that now we did this 3-arm study, everolimus, Afinitor alone, 10 milligram, versus pasireotide, 60 milligram every 4 weeks, and the combination. We have data which is now embargoed because it's going to be presented as ESMO in September, so I'm not allowed to talk about it, but I can tell you that there are some interested results from the combination. That's the only thing I can say. There is another study which is ongoing here in US, and that is comparing lanreotide, 120 milligram versus placebo in lung mets. And I know that Eric is involved in this study, so he's going to talk about it. So you have seen this from NCCN guidelines for the treatment of lung carcinoids. I must say I'm not totally agreeing what they are writing here, because as you can see, they have put cisplatin and etoposide everywhere. So as soon as you have proliferation, the patient goes for cisplatin and etoposide. I mean, so I can't agree with this one. But this is NCCN, which is an honored organization in US. But they have done a sub-analysis, which I want to show you. And they are, in this group, showing that you can use as first-line somatostatin analog, or you can use everolimus, you can use interferon in these low-grade tumors. So they have started to modify. They are not just pushing for the old cytotoxic treatment. So I think in next version of these NCCN guidelines, I think they will start to look like this, what you see here. And ESMO guidelines, I'm of course responsible by this myself, so I shouldn't maybe talk so much about it, but as you can see, we put up somatostatin analogs as first-line treatment in most low-grade or intermediate grade tumors. And then we add interferon alpha, PRT, and also everolimus. And I must say that these guidelines are really accepted in Europe as a standard of care among most physicians. Then we went into the most recent update. What we did was, ENES, European Neuroendocrine Tumor Society, decided that we should look more into the lung nets because we have been focusing on gastrointestinal nets all the time. So we invited a lot of lung doctors to work together with us. And this is the treatment algorithm for lung nets, which is published last year. And as you can see, again, it's hard for me to read here, so I go down here. But you can see that yeah. Good. Thank you. So, if you have hormone-related symptoms which occur in less than 10% of all typical and atypical neuroendocrine tumors, of course we had to look at the syndrome. If you have a carcinoid syndrome, you have somatostatin analog, of course, which is very important. And then you can do leukoregional treatments. You can do embolization, radioembolizations, interferon, and PRRT. Cushing syndrome is very, very often a difficult syndrome to deal with. Usually we end up with take out the adrenals, and the patient had to take supplementation with corticosteroids. But the important thing is to control the cortisol secretion. If you look at the control of the tumor growth, and we have the typical lung carcinoid, we have, of course, surgery as first line. You can also have observation if you have a very small tumor, slow growing, not happening anything during the 3 or 6 months observation period. But otherwise, you go for somatostatin analog, and then if that is not enough, you can add on top that either interferon or everolimus affinity. If you go to a typical carcinoid, somatostatin analog is still first line in low proliferating, the same for interferon. Everolimus, I think, is even better in this group because the patient with a typical carcinoid will respond even better on everolimus. And then you have a possibility of chemotherapy, temozolomide, and of course PRRT, which we have been using in Europe for more than 10 years now, with lutetium or yttrium. If you look at the prognosis for lung neuroendocrine tumors, I pointed out for the typical carcinoids, the prognosis is excellent. 5 and 10 years survival is the same. A typical carcinoid has somewhat lower 5-year survival and 10-year survival rate. But here I can say that when we look at our most recent figures, we are approaching more and more 60 to 75% 5 years and almost around 70% 10-year survival. You have late occurrences, so you must follow these patients. We have seen recurrences after 30 years. One patient that had been operated for a typical carcinoid had eye metastases after 30 years. And what are prognostical favorable signs? Typical carcinoid, no lymph node metastasis, as we heard before, low Ki67, and then we have another marker we are doing in our center. We stain for CD44, and if that is positive, it's also indicate a more positive outcome. So, what do we need for the future? First of all, we need new biomarkers. still that the patients are diagnosed in advanced stage with metastases, many of them. So we must have more sensitive biomarkers which can pick up these patients earlier. We must have more individualized treatment based on tumor biology, and I think we will learn more and more using molecular profiling. Combination of drugs. We already combined Afinitor with somatostatin analog. We start to combine Afinitor with temozolomide. So there's a lot of new combinations coming out. We combine new drugs with PRT, and then we have completely new drugs. And I can just mention, because many of you know about this Advance study that has been around in the Facebook media for a while. That is a study they are just starting using an oncolytic virus. And this oncolytic virus, we modified the promoter. We took out the original promoter from the adenovirus. We put in the promoter for chromogranin A, which means that the promoter is regulating the growth of the virus. So the virus is only growing in tumor cells. If it comes into normal cells, it just stays there. It doesn't do anything. But in the tumor cell, it starts to grow, and the tumor cell bursts, and the tumor cells die, but at the same time, they send out a lot of new peptides, amines, and other substances that stimulate the immune system. So in the study, we are infusing the virus into the liver to take the liver tumors, and then they see now that they affect the immune system, is activated and takes the tumors outside, in the bone or in the lungs and so on. So it's just started. The first 2 patients have been included, but you also on the lowest dose, it seems to have some activity. So this looks very promising. I can't tell you more, but we have to do 12 patients in the phase 1, and then 35 patients in the phase 2. After that, we know if this is a good treatment for the future, but it's a part of the program for immunotherapy. Thank you for your attention.